Hello everyone, my name is Mark Patesta. I go to LECOM, and today I'll be presenting on a case of Hashimoto's encephalopathy. Hashimoto's encephalopathy is a rare, often underrecognized and underdiagnosed cause of altered mental status. Hashimoto's encephalopathy, having ties to Hashimoto's thyroiditis, has been the subject of debate for decades. Hashimoto's encephalopathy has been met with diagnostic difficulty. The infrequent nature of the disease, lack of routine antibody testing, and use of alternative names have all contributed to the unfamiliarity with the disease. Despite these challenges, understanding the autoimmune background and proposed pathogenesis of disease is vital for improving patient outcomes. This case presentation involves an 87-year-old man with no past medical history of neurological disorders or endocrinopathies, and he is presenting with transient altered mental status, a significant change from his sharp baseline. Subsequent workup in the ED was unrevealing, with a negative UA head CT and no electrolyte abnormalities, and a chest x-ray showing a left-sided pleural effusion. The patient was admitted for further workup. During the course of his hospital stay, his degree of orientation varied. Most notably, he was oriented to place and person, but not time. On exam, no Babinski was present. He had 1+ reflexes bilaterally and was able to follow commands, speak clearly, but when asked to reproduce sentences, he misplaced words consistently. His coordination was intact and no signs of Parkinsonism were present. He also experienced an episode of unresponsiveness with no response to sternal rub. Hypertensive encephalopathy was ruled out and subsequent head MRI and EEG were ordered, both yielding no pathognomonic findings. A lumbar puncture was performed, resulting in negative findings for various sources of infection, which are highlighted in the table below. Based on elevated CSF protein of 58, CSF white count of 3, and previous negative workup, the patient was believed to be a candidate for IV immunoglobulin and steroid therapy due to suspected autoimmune encephalitis. Follow-up labs were ordered, and most notably the patient had high levels of thyroid peroxidase antibodies and thyroglobulin antibodies. A diagnosis of Hashimoto's encephalopathy was strongly suspected, and the patient was treated with 4 doses of IV immunoglobulin and high-pulse solumedrol. Moderate improvement in the patient's mental status was noted, and he was subsequently discharged on a regimen of prednisone 100 milligrams every 4 hours. On an outpatient follow-up visit 3 weeks later, the patient's altered mental status had resolved. It is suggested that Hashimoto's encephalopathy is directly related to Hashimoto's thyroiditis. Despite there being over 50 years of observation, debate still surrounds whether the disease of Hashimoto's encephalopathy is due to coincidence with Hashimoto's thyroiditis or whether it is directly correlated. In part, this is due to the disease being rare, having an estimated prevalence of 2.1 per 100,000 in the adult population. Rareness of the disease, alternative names such as steroid-responsive encephalopathy associated with autoimmune thyroiditis, and lack of routine physician antibody testing likely all play a role in underreporting and underrecognizing. Highlighted on the table on the right, several proposed mechanisms of disease can be seen. Most notably, mechanisms include direct toxic effect of thyroid-releasing hormone, chronic limited inflammatory lesions of the cortex and meninges, and decreased cerebral perfusion. Manifestations of the disease typically begin with altered mental status or stroke-like symptoms, and as the disease progresses, the patient may develop psychosis and/or seizures. Mainstay first-line treatment for autoimmune encephalitis is a combination of IV immunoglobulins, IV steroids, and plasma exchanges. Furthermore, this case highlights the importance of considering a wide differential diagnosis when working up altered mental status and recognizing the complexities of Hashimoto's encephalopathy. The key takeaway from this case is the need for increased awareness among physicians and more frequent antibody testing to facilitate accurate diagnosis and improve patient outcomes. Further collaboration amongst researchers and physicians is crucial in uncovering the pathogenesis. Thank you.